Good morning, everyone. In the tradition of the very first ACIP meeting, I'm very pleased to introduce the influenza session. I'm going to keep my remarks brief because we have a very full agenda this morning. Next slide, please. I'd like to thank all of our work group members, and I'd particularly like to note that we have a new member on our committee, Ed Belongia, who's just joined us. We're very pleased to have him. Jeff Duchin, who all of you remember, continues as a consultant with us. And I'd particularly like to acknowledge the work of Lisa Grosskopf, who you'll hear a lot from her this morning, and she's really worked tremendously hard to bring you the information that you'll hear later today. Next slide, please. So our work group has mostly focused on vaccine effectiveness estimates for live-attenuated vaccine and inactivated vaccine. We've heard data from the U.S. Flu VE Network, from the Armed Forces Health Surveillance Center, and we've also heard from MedImmune on a post-marketing study of quadrivalent LAIV. Next slide. So our agenda for this morning, Lisa will present an influenza surveillance update. We'll then hear from Brendan Flannery on an update of effectiveness of LAIV versus IIV in children and adolescents. We'll hear from Dr. Chip Altman of BioCSL about the Afluria influenza vaccine administered via PharmaJet that you heard about in the updates earlier this morning. And then Lisa finally will give us a brief update on influenza vaccine supply. So with that, I'd like to introduce Lisa.
Okay, good morning. Thanks very much. I'm going to start out with a brief snapshot of the current influenza activity that's been reported through our surveillance systems. We're going to change gears briefly after that to discuss some pertinent topics from the season that just completed, the 2013-14 season. And at the end, we're going to circle back to the upcoming season and some things that we might expect to see. So this is the first slide I mentioned. This is the most recent snapshot of current influenza activity in the United States. These data come from FluView. Actually, pretty much most of the data that I'm presenting today come from FluView, and I'd like to thank the folks on our surveillance and outbreak response team for preparing these slides. This is the summary of influenza activity reported weekly to CDC by state and territorial epidemiologists. This is the most recent report from the most recent FluView available, which is week 42 of the calendar year. That is the week ending October 18th. Overall, we can see from this that influenza activity is still fairly low across the United States. Most states are reporting either sporadic or no activity. However, we are starting to see some signs of the beginning of an uptick in activity. For example, we have several states shown in yellow that are reporting local activity. We also have Guam reporting widespread activity. Leaving the current season for the moment and returning to the 13-14 season, we're not going to present the full battery of data on this season in the interest of time, but just a couple of points of interest. The first of these has to do with patterns of influenza-associated hospitalizations by age. This is data from fluserve.net, and this slide and the next one summarize laboratory-confirmed influenza hospitalizations reported to the system from October through April 2014. This is last season. These are rates of hospitalizations, rates shown on the y-axis, calendar week is shown on the x-axis, and different age groups are represented by different colors on the plot. For the 2013-14 season, as is not atypical, the highest rates of hospitalization were observed among those 65 and older, the highest, most elder age group in this population. Whereas in the previous season, 2012-13, the next highest rates were observed among the very youngest in our population, those 0 to 4 years of age, which is also not atypical. Last season, the next highest rates of hospitalization were actually observed in middle-aged adults, that would be those aged 50 through 64 years. That's shown in pink, right under the line for 65 and up, which is the green line. The next slide looks at some of the same data in a slightly different way. This is the proportion of hospitalizations contributed from each age group. Our color scheme is similar here. We have the pink represents the 50 through 64-year-olds. Purple, just below that in each bar, is 19 through 49-year-olds. We have several seasons here from the 2009-10 pandemic season all the way on the left through the 13-14 season on the far right. 2009-10 was, of course, a 2009 H1N1 pandemic season. This past season, 13-14, was the first H1N1 predominant season we've had since pandemic. It's interesting to note that the proportion of hospitalizations contributed by those adults 19 through 64 years of age, that's young and middle-aged adults, was 57%, which is the highest actually it has been since the pandemic period. This slide is also from the 13-14 season and actually into the the 13-14 season and beginning the 14-15 season. This is a summary of influenza-associated pediatric deaths. Seasons represented are from 2011-12 through 14-15. We have one death thus far reported for the current 2014-15 season. For the 2013-14 season, a total of 109 deaths have been reported to CDC. There's a breakdown by types at the table above the graph. Among those isolates for which subtyping was performed, the majority of those 44 were due to influenza A. We have H1N1. We have relatively fewer for influenza A, H3N2. B viruses are also represented. This is the last 2013-14 specific slide I'll show. This shows results of influenza positive tests reported to CDC weekly by the US, WHO, and National Respiratory and Enteric Virus Surveillance System laboratories. The bars and the different colors represent the different types and subtypes of flu vaccine where that, influenza virus is isolated where that information is available. Green represents B viruses, red AH3N2, orange 2009 PDM-H1N1, and yellow is influenza A viruses which were not further subtyped, so we don't know if they're H3 or H1. The notable thing about this graph is we see a preponderance of orange. Again, as mentioned earlier, 2013-14 was an H1N1 predominant season, with the vast majority of isolates being pandemic 2009 H1N1. We do also see some H3, however, much less shown in the red, as well as some B. There was a bit of an uptick in B towards the middle to end of the season, but overall a predominant 2009 H1N1 season. So switching gears back again to the current season, this is the same graph, but this is for the season as the data exist thus far. We only have 3 weeks of data at this point. This is for weeks 40, 41, and 42 of the calendar year. Again, the most recent data is the week ending October 18th. The color coding here is the same. We see B in green, the AH3N2 in red, and untyped A's are in yellow. There is also, although it is probably exceedingly difficult to see, a tiny bit of orange between the red and the yellow, which represents the approximately 1% of 2009 H1N1 that have been observed so far. We are again only 3 weeks into this, and it is far too early to really make a statement about what kind of season this is going to be, whether it will be H3 or H1. However, at least at the present time, we are not seeing very much in the way of 2009 H1N1. So shifting gears away from surveillance and into a little bit of discussion of what is being seen specifically with H3N2 viruses as we come into this season. The vaccine virus for the Northern Hemisphere vaccine for this season, the 2014-15 Northern Hemisphere season, is the same as it was for the 2013-14 Hemisphere season. That is A Texas 50 2012. Of note, in September, the WHO met to convene and discuss the recommended vaccine composition for the 2015 Southern Hemisphere vaccines. The Northern Hemisphere recommendations are usually done in February, Southern Hemisphere in September. And of note, they recommended a different H3N2 virus, which is A Switzerland 9715293 2013 for the upcoming Southern Hemisphere 2015 vaccine. Some of the data on which this was based, I'll briefly summarize here. Antigenic characteristics of H3N2 viruses that were collected from February through August of 2014 were assessed using panels of post-infection antisera, including both hemagglutinin inhibition and virus neutralization assays, as is typically done. Many isolates were still well inhibited by antisera raised against the cell-propagated reference virus A Texas 50 2012, which is representative of what's in the vaccine, and A Victoria 361 2011, i.e. they were similar to viruses included in the 13-14 and in the upcoming 14-15 Northern Hemisphere seasonal vaccines. However, an increasing proportion were poorly inhibited by these antisera, as well as antisera raised against the egg-propagated A Texas 50 2012. So on that basis, the 2015 Southern Hemisphere H3N2 is a Switzerland, as noted earlier. And we may, based on this information from surveillance, expect to see some antigenic drift among H3N2 viruses in the Northern Hemisphere for the upcoming 14-15 season. Again, I'd like to acknowledge everybody, particularly the folks in surveillance and outbreak response who put together all this data and were very kind in helping get these slides done. Be happy to take any questions.
I'm going to just break in here and have a note here that the Wi-Fi here is not responding to the large numbers of people in the room logged on. So if you don't really need to be on, please log off. Okay. Any questions at all for Dr. Groskopf?
Thank you.
Oh, Dr. Ungold. Sorry.
I know it's, Lisa, it's very early in the season, but just the very early indications in terms of the H3N2 strains that you're seeing, are they a reasonable match for what's in the vaccine?
I believe I do have, I actually don't have that information yet. It's a little too early to get the antigenic characterization data for the isolates that have seen thus far this season. Antigenic characterization-wise for 13-14 overall match was pretty good. But we probably won't have antigenic characterization for another several weeks for the current viruses.
A follow-up question to that, and just based on several years of doing this, how predictive are the first few weeks? Yeah, I think you showed the first 3 weeks of this year in terms of the distribution of H3 and H1 viruses. But how predictive is that from past experience in what we're going to be seeing in the next several weeks to months?
I don't know that it's possible to necessarily state that generalizably for all seasons. Of course, last season we saw a fair amount of H1N1 out the gate, and it did persist. We did see some later uptick in B, of course, but nothing near the prevalence of the H1N1. Difficult to make that any statement generalizable for influenza, I think, across seasons.
Thank you. Other questions? Okay. We're moving to Dr. Flannery with an update on the effectiveness of live-attenuated and inactivated seasonal influenza vaccines in children and adolescents.
Okay, great, thank you. Good morning. The U.S. Flu V network provides estimates for seasonal flu vaccine effectiveness against circulating influenza viruses each season. In past seasons, the Flu V network has presented to ACIP interim estimates of vaccine effectiveness during the season, as well as end-of-season estimates. For 2013-14, the end-of-season estimates were similar to interim estimates and will be published. But today I'm going to present an analysis of the Flu VE network data to estimate vaccine effectiveness in two types of vaccines: live-attenuated vaccine, just abbreviated throughout here as LAIV, and then all the inactivated vaccines together, just abbreviated as IIV. This is among children and adolescents 2 to 18 years over 3 influenza seasons. So I'd like to begin by acknowledging the many contributors to the data that I'll present today, contributors to the U.S. Flu VE network. The Flu VE network is a cooperative agreement between CDC and 5 sites. The sites here and the principal investigators at the sites are shown with the stars. The use of live-attenuated vaccine among children and adolescents has been increasing at these sites, which allows us the opportunity to estimate vaccine effectiveness for live-attenuated vaccine specifically. So the objectives for today's presentation are two. First of all is to compare live-attenuated vaccine and inactivated vaccine effectiveness among children and adolescents during 3 influenza seasons, the past 3 seasons, 11-12, 12-13, and 13-14, and then to summarize other data from observational studies that evaluated live-attenuated and inactivated vaccine effectiveness among children and adolescents during this past season, the 13-14 season. So just as a review of the methods for the U.S. Flu Vaccine Effectiveness Network, participating sites enroll outpatients age 6 months and older who present with acute respiratory illness and cough within 7 days of symptom onset. It's a prospective case control study that uses a test-negative design, and what that means is that all enrolled outpatients are tested for influenza by RT-PCR. Cases are the outpatients with confirmed influenza. Controls are the outpatients who test negative for influenza. The analysis compares odds of vaccination in the flu-positive cases and the flu-negative controls. Vaccination status is confirmed by medical record or immunization registry data. We have included only those children and adolescents considered fully vaccinated by ACIP recommendations 14 or more days before illness onset. VE is calculated as 1 minus the odds ratio times 100. Estimates are adjusted for age, sex, study site, days from illness onset to enrollment, high-risk health conditions, calendar time, race, ethnicity, and a parent-rated general health status. This analysis only includes enrollees 2 to 18 years of age who received only one type of vaccine in a particular season. I'm going to present LAIV versus no vaccine effectiveness, effectiveness of inactivated vaccines versus no vaccine, the relative effectiveness of LAIV to IIV, which directly compares these two groups, will be the last part of the presentation. So since the pandemic, the H1N1 virus, shown here in the orange bars, has circulated as at different levels in each of the seasons. The 13-14 season had the largest number of H1N1 pandemic viruses since the 2009 pandemic. And this simple figure shows the number of influenza-positive subjects among all ages enrolled in the Flu VE network according to the type or subtype of the flu virus that was identified in that particular person for the past 3 influenza seasons. The cases due to 2009 H1N1 pandemic virus are shown here again in orange, identified in each of the 3 seasons, but contributed a small proportion of all cases in the 11-12, the first set here, and the 12-13 seasons. So for the next 2 slides, I'm going to present the vaccine effectiveness for the live attenuated influenza vaccine. And again, the other children would have received no vaccine here. So live attenuated vaccine effectiveness against medically attended influenza is shown here with seasons on the horizontal axis, vaccine effectiveness on the vertical axis. For the 11-12 season and the 12-13 season, vaccine effectiveness for LIV was moderate. In the 13-14 season, we have no estimate of vaccine effectiveness, although the confidence interval does include positive and negative effectiveness for LIV. The numbers here at the bottom show total enrollees flu positive, and then the LAIV recipients that were flu positive. So pay attention, I think, in these slides to the small numbers that we have for the different comparisons. This graph is for 2 to 18 years old. Then we break these out by age group, 2 to 8-year-olds, 9 to 18-year-olds. The same pattern that we see here, 11-12, 12-13 moderate effectiveness that's significant, 13-14 no effectiveness with confidence intervals that are both positive and negative. For 9 to 18, the numbers are small, again, of the LAIV recipients that were positive for flu, but no real indication of a difference in terms of the vaccine effectiveness among the 9 to 18-year-olds over the 3 seasons. And again, this is for all medically attended influenza. So, comparison with inactivated influenza vaccines effectiveness, we see here the same kind of graph, 2 to 18-year-olds, the vaccine effectiveness in 11-12, 12-13, 13-14, all moderate, all significant, confidence intervals that do not include 0. The numbers are slightly larger here for the inactivated vaccine recipients that were flu positive. We break these out by age group, and again, see a similar pattern to all ages, 2 to 18, when we look at 2 to 8 and 9 to 18 years. Moderate effectiveness, statistically significant for each of the seasons. So in this comparison, we're looking at side-by-side live-attenuated vaccine and inactivated vaccine against no vaccine, really, but now by influenza type and subtype. So the graphic is slightly different. The vaccine here is in the horizontal axis. Vaccine effectiveness is still the vertical axis, and the numbers here at the bottom would correspond to, say, LAIV positive, IIV positive, and it would go that way. So this is 2 to 18 years old by type or subtype. So for the H1N1 pandemic 09 virus, for the 3 seasons now put together, since we didn't have circulation of all 3 types and subtypes in the 13-14 season, we really see very low effectiveness for LAIV against the pandemic H1N1 virus, moderate inactivated vaccine effectiveness against H1N1 09, slightly lower than overall, but significant effectiveness for H3N2 for inactivated, and very similar point estimate for live-attenuated, and moderate effectiveness for B strains, similar for LAIV and IIV. Just one other graph here for the comparison, the side-by-side comparison. This is among 2 to 8-year-olds. Again, the numbers here become small in some groups, especially for LAIV, but we see a very similar pattern in the 2 to 8-year-olds with low effectiveness for LAIV over those 3 seasons against the H1N1 pandemic 09 strain. Similar effectiveness for both vaccines, for H3N2 and for B. Okay, then finally, the last part of the presentation for the US VE network data is a relative effectiveness comparison of LAIV versus IIV. I'm just going to show a graphic to explain a little bit how this was set up. This now switches the axes so that on the bottom is a odds ratio. When we have an odds ratio that's less than 1, it favors live-attenuated vaccine, and an odds ratio greater than 1 favors inactivated vaccine. So I'm going to use this to show the comparison, the relative effectiveness of the 2 vaccines. So this is the season now is on the vertical axis, 11-12, 12-13, and 13-14 seasons. This is the 2 to 18-year-old age group. This is for all flu. For these seasons, the adjusted odds ratios there's no relative effectiveness advantage for either vaccine. The confidence intervals include 1 for the 11-12 and 12-13 seasons. There is a significant advantage for inactivated vaccine among the 2 to 8-year-olds for the 13-14 season. Okay, breaking this down by age group, there is a suggestion of effectiveness or relative effectiveness advantage of live-attenuated vaccine in 11-12 and 12-13, but again, the confidence intervals include 1, so these are not significantly different. There is a significant advantage for inactivated vaccine in the 13-14 season among the younger age group. We did not see any differences in effectiveness comparing LAIV directly to IIV in the past 3 seasons among the 9 to 18-year-olds. So the limitations for the US VE network data are that we have a limited ability to differentiate between a single season effect and an H1N1 pandemic vaccine virus effect, because there was limited circulation of H1N1 pandemic virus in the network sites among children from 2010 to 2013, or those seasons between 2009 and the last season. And further, our ability to measure vaccine effectiveness among children by vaccine type, so live-attenuated versus inactivated vaccines, depends both on the vaccine uptake and requires a large sample size. So we have a limited ability with the flu vaccine network to be able to control for potential confounding variables in these comparisons where we're looking at age group and specific vaccine type. But in summary, for the VE network data, during 2 years, 11-12 and 12-13, relative effectiveness favored LAIV among young children, but was not significant. During 13-14, relative effectiveness favored IIV versus LAIV in young children and was significant. The pandemic H1N1 was predominant for the first time since the pandemic in 13-14. The subtype analysis is consistent with low vaccine effectiveness for the H1N1 pandemic vaccine virus. We cannot rule out, however, based on just the US flu VE network data, a specific issue related to 13-14, whether that's study enrollees or design, unmeasured confounding, or a vaccine-specific issue. And for that reason, we asked both the manufacturer and the Department of Defense to look at the data that they had for LAIV effectiveness. They were both presented to the working group, and they have kindly provided some slides to share with you today. So the second part of this presentation then is a review of the available data from the 13-14 season on LAIV and IIV effectiveness in children and adolescents. So the first 4 slides are were provided by MedImmune. These are slides from a post-licensure effectiveness study that MedImmune is conducting. This is the first season of that study. They presented the summary first. The key take-home here is that the MedImmune's post-licensure study found similar results to the results that I presented from the VE network. However, they do have LAIV effectiveness against influenza B. We did not have enough B in the flu vaccine network to have an estimate specifically for B for LAIV that was significant, but they do find no significant effectiveness for the H1N1 pandemic virus overall. They found significant differences in effectiveness observed by lot shipping time, and I'll present that quickly at the end. They have no clear explanation at present. They are conducting comprehensive investigations into potential explanations. They do believe that there are differences in lot that may be explained by potency loss, or the H1N1 vaccine virus strain, that particular virus is more susceptible to thermal degradation due to a unique hemagglutinin stock sequence. They have published those results, the references here. And the sequence is not present in the seasonal influenza LAIV strains, which were used for the clinical trials of LAIV versus IIV. The MedImmune study, just to go through their methods quickly, is community-dwelling children 2 to 17 years of age. There are 4 sites. 2 of them are sites for the VE network, but the children are not recruited from the same clinic, so there's no overlap with the actual data that were presented from the VE network study. They use a similar design to the CDC study, which is to say it's a test-negative design using RT-PCR confirmed influenza. The data that I'm going to show you from MedImmune are based on about 1,033 children included in this analysis. The easiest way to look at this, I think, is to compare the overall for LAIV to the overall here for IIV. So overlapping confidence intervals, but a suggestion that there was lower effectiveness for LAIV. Broken down by subtype, it's clear that there was a difference in the point estimates for the H1N1 versus in live-attenuated versus the inactivated vaccine. For B, the estimates are similar and high for both vaccines. And finally, this is an analysis that they are conducting to look at the week that the lot was shipped. Weeks 4 to 9 represents the beginning of August until the middle of September. Weeks when the lots may have been exposed to temperature. high temperatures, and that could have affected the lots. Specifically the potency of the H1N1 2009 vaccine virus. So they found no effectiveness for the children who received those lots of vaccines versus a pretty reasonable effectiveness estimate for early or later shipments. We did not see this same effect in the VE network data analyzed with the same information about the date of shipping lots. The second slides that I'm going to present for the additional data are from the Armed Forces Health Services Health Surveillance Center. This is the methods that they use in this particular analysis. They have overlapping periods for vaccinations and outcomes for the 2013-14 season. This only includes the Air Force dependents, the 2 to 17-year-old age group. The reason that these are limited to Air Force dependents is that the Air Force is the only service that has a database of immunizations like a registry for all of the dependents. They also use a test a negative design. However, they do include both culture and rapid PCR positives in their lab-confirmed influenza cases. Their test negatives, however, are essentially all PCR-confirmed negative. So even though they have PCR or culture, if it's a PCR result, they essentially all have PCR negatives to be included in this analysis. The children are considered vaccinated if vaccine was received at least 14 days prior to the lab test. So the summary of their findings, I'm not going to present the specific data, but the data were presented to the work group. They found moderate vaccine effectiveness for any vaccine type, or essentially for any vaccination, and a significant VE for inactivated vaccines for all age groups, so that 2 to 17-year-old age group. They have no vaccine effectiveness for LAIV among all the age groups, 2 to 17-year-olds. And the low LAIV, they believe, may be related to the predominance of H1 circulation this season. They did not have a large enough sample size to have significant vaccine effectiveness estimates when they analyzed by subtype, but the subtype analysis is very consistent with no or low vaccine effectiveness for the pandemic H1N9 strain. Okay, so a summary then, in conclusion of all of the observational data presented today. I presented 3 U.S. studies for the 13-14 season that all use the test negative design and all report low VE for the quadrivalent LAIV. All 3 reported higher and significant vaccine effectiveness for inactivated vaccine among the same groups of children and adolescents. All 3 studies reported low VE for LAIV4 against the pandemic 09 strain in 13-14. The MedImmune post-licensure study reported significant VE for the quadrivalent LAIV, similar to inactivated vaccine against influenza B Yamagata, but not H1N1 pandemic 09. Thank you very much.
And I think, Dr. Grosskopf, you're going to have some summary slides here as well.
Thank you. In the interest of sort of putting this information in the context of recent decisions that were voted upon in June related to LAIV and IIV for children, I just have a few summary slides. Prior to the current season, healthy children aged 2 through 8 years would have been recommended to receive either LAIV or IIV with no specific preference recommended for either vaccine. Leading up to the June 2014 ACIP meeting, there was discussion of several studies that suggested potential advantages of LAIV over IIV for children, including better vaccine efficacy, particularly for the younger children, as well as better heterotypic protection against drifted strains. We also were aware that several countries, including Canada, the United Kingdom, Israel, and Germany, as well as 2 U.S. states, Washington and Oregon, had within the past several seasons previously expressed some degree of LAIV preference for young children. The age ranges and some of the specific details of the populations to which the preference applies vary, but some form of language for preference was expressed by these jurisdictions. In June 2014, ACIP recommended that LAIV should be used when available for healthy children aged 2 through 8 years, following a grade assessment of data from 2 comparative randomized control trials, which was subject to grade analysis and was presented at the February and June 2014 ACIP meetings. So a little bit of information from that grade assessment. Those of you that were here know that there were a good number of slides presented and a pretty large number of outcomes discussed. This is probably the most relevant outcome for this particular conversation, which is laboratory confirmed influenza, which was valued as a critical outcome for policy decision making. And the data evaluated in this slide are from not observational studies, but from 2 randomized controlled trials, Ashkenazi 2006 and Belshi 2007. These were both studies that were comparative studies of LAIV and inactivated vaccine. They included both arms for 1 arm for each of these vaccines. And overall, pooling the results from these studies, the pooled risk relative risk ratio was 0.46, with a confidence interval of 0.39 to 0.54, favoring LAIV for providing increased protection relative to IIV against laboratory-confirmed influenza. And the forest plot is set up similarly to what Dr. Flannery presented to the left of the line in the forest plot that indicates that LAIV is favored. Now, one thing to remember about this particular analysis is that the influenza cases that were included all influenza types and subtypes. So this is for all influenza, all AH1N1, H3N2, and all B, without regard to antigenic similarity to viruses in the vaccine during that given season. We've gone back and looked at again, some of the type-specific information to the extent that it's reported in these papers. Belshi 2007 was conducted during the 2004-2005 season. This was a randomized, placebo-blinded comparative trial of LAIV and IIV, so there were placebos used, although if a child got, for example, active LAIV, they got a saline placebo for IIV, so you didn't have children who got only placebo, and we can't therefore assess absolute VE from this study. It's only relative VE of LAIV as compared to IIV. All of the, as it was reported in the paper, all of the H1N1s that season that were isolated over the course of the study among the flu cases were antigenically matched to the vaccine H1N1, which at that time was A. Caledonia 20-1999. This study was conducted over the 04-05 season. It was pre-pandemic, so the 2009 H1N1 virus was not yet in the mix for circulation or vaccine. Relative VE for LAIV versus IIV specifically for the H1N1 was 89.2 and had a significant confidence interval of 67 to 97%. Different situation for the H3N2s that season. All were antigenically mismatched compared to the vaccine. All were drifted. And nonetheless, the relative VE for LAIV versus IIV was significant with a relative VE, again, not absolute, relative, of 79.2% with also a significant confidence interval of 70.6 to 85.7. B viruses from both lineages were circulating and were represented in the samples from that study. Some matched vaccines, some did not. Relative VE for the matched strains was 27.3, but with a confidence interval it included no effect, so not significant. For those mismatched, 6.3%, again with a confidence interval that was not significant. Ashkenazi, 2006. This was the second randomized trial. This was an open-label comparative trial of LAIV versus IIV. No placebos were given. This was conducted over the 2002-2003 season. The authors note in the paper that among the cases, isolates that included A H1N1, H3N2, and B viruses that were regarded as antigenically similar to vaccine were represented, as well as some H3N2 that were regarded as antigenically distinct. The vaccine virus was the same as for the previous study, A New Caledonia 2019-99. Again, this was a pre-pandemic study. Results specific to the mismatched strains alone are not reported. They're mainly relevant for H3N2. For H3N2, for type-specific H3N2, but without regard to match, and again, some of the viruses did not match. The relative vaccine efficacy of LAIV as compared with IIV was minus 47.9 with a very wide confidence interval. So difficult to interpret, probably due to small numbers in the sample. To summarize, the comparative studies of LAIV and IIV were conducted prior to the 2009 pandemic. We're not aware of any H1N1 pandemic 2009 specific efficacy data that is available from RCTs. There are also relatively few effectiveness data for monovalent LAIV that was administered during pandemic. 2013-14, again, was the first H1N1 predominant season that we've had since the 2009 pandemic, and the data presented today provide what we feel is the first clear indication of suboptimal effectiveness of LAIV for H1N1 pandemic 2009 virus. As yet, this is all still an investigation in progress. The explanation for the 13-14 findings is not known. As alluded to by Dr. Flannery in his presentation, differences by lot shipping time and the MedImmune data are under investigation currently. But we do see good VE for LAIV against influenza B in this data, and also seeing similar findings for H1N1 in 3 different data sets. So it doesn't seem clear that it's necessarily a specific handling issue, as we might expect that to affect influenza B as well. Current data are from observational studies. That's another thing that's important to consider, the data that were presented today. So there's always the potential for biases or residual potential confounding. Again, though, however, since we're seeing somewhat similar observations at this point, still somewhat preliminary, we hope to have more data and report back on this over time. That does seem to somewhat strengthen the observation. As mentioned in the last presentation, the LAIV H1N1 PDM 2009 virus, that is the virus that is included in the vaccine, may be less stable or more subject to thermal degradation than seasonal H1N1 LAIV viruses have been. That's the data that's reported in Cotter et al. 2014. The sequence in the hemagglutinin stock that confers that susceptibility is relatively specific to that virus, and to our knowledge is not known to be common among seasonal H1N1 viruses. It's conceivable that this could potentially affect stability and or the replicative fitness of the vaccine virus. This is a live virus vaccine, so in order to work, it does need to multiply in the nasal mucosa. That would be a potentially biologically plausible explanation and could also be consistent with previous good VE observed with seasonal H1N1 strains, as well as the observation of good effectiveness of the LAIV for this past season's B isolates. Looking forward, the 2014-15 vaccine's already been produced. We're not anticipating any changes at this season. The U.S. Flu VE network is receiving additional resources to increase enrollment of children, and we will be continuing to evaluate this issue. The work group is, of course, going to continue to discuss additional data from these and other sources as it becomes available.
Thank you, Lisa. I think there will be some discussion here. So, Dr. Karen.
So I wanted to thank you, Lisa and Brendan, for really excellent presentations. Clearly, there's been a problem identified with H1N1 component of LAIV, and I think the silver lining in this is that we do have a strong VE network and information from DoD. I'm not sure we would have recognized this problem this quickly 5 or 10 years ago. I actually wanted to start with a question that's really a recapitulation of something that you asked, John, and it's a question for Brendan. And the question has to do with early circulation of A strains and prediction of what will circulate during the season, would it be a fair statement based on the VE network data to say that generally one A strain predominates and the A strains that is identified early in the season tends to be the predominant strain? Would that be a fair statement?
In the season that followed the pandemic, there was pretty similar circulation of the pandemic H1N1 virus and the H3N2 viruses in that particular season. That's uncommon, but looking at that analysis, that is one analysis that was able to actually give subtype-specific estimates for VE. So if we did have co-circulation of both A subtypes this season, we would have a bit more data on this phenomenon where we really could compare the H3 and the H1 VE for those two vaccines for the same season. You're right that in most seasons there seems to be one A that's dominant, and then the subtype-specific analysis doesn't make a whole lot of sense until we combine seasons with all the difficulties of combining seasons and different vaccines.
Dr. Ringgold.
Thanks. A question and a comment. So the question is whether this stalk issue is that just an H1N1 issue, or is that also an H3N2 issue? Whatever this issue, I don't quite understand the stalk issue, but maybe you could explain that a little more and whether it extends to both of the A viruses that are in the vaccine. The comment has to do with, and I understand the issues of observational studies and confounding, but I'm personally not persuaded confounding and uncontrolled confounding is the issue here. I certainly don't see how it could pertain to the effectiveness estimates for the H1N1 and not for the B. So I'm personally not persuaded confounding is the issue here.
Thanks. With the regard to the question about the H1N1, to our knowledge, that's something that's specific to the specific sequence that confers that specific vulnerability is an issue with the PDM 2009 H1 vaccine virus. And my understanding is that it was observed in the wild type 2009 pandemic viruses early on in pandemic, but that there since then has been some evolution away from that, and the current wild type viruses are more stable. To my knowledge, this is not an issue with seasonal H1N1 viruses or with the H3N2 viruses.
Dr. Harrison.
Yeah, so thanks. Very interesting but disconcerting data. I'm a little unclear about the moving forward part. In terms of, are there ways to assess the current lots that have been produced and to avoid this issue of obviously the problematic lots from last year?
We're looking forward to having some more and possibly from some more years information from DoD in the run-up to the February meeting. So that's one task, and obviously the U.S. Flu VE network will be continuing to collect data. With regard to moving forward and vaccine, again, the vaccine's been produced for this season. We can ask representatives from MedImmune if present to comment on that.
Dr. Kieran, and then Dr. Camp, and then Dr. Romero.
So I actually have a question for MedImmune specifically, and it has to do with replacement of the 2009 pandemic H1N1 component with a more stable virus. I mean, this paper that was published earlier this year talked about a more stable, later isolated variant.
Yes, as Lisa mentioned, it's Kathy Cooling from MedImmune. Is this on? No? Yes, it's on. Okay. This is Kathy Cooling from MedImmune. As Lisa mentioned earlier, this is a very kind of oddball amino acid sequence in the stalk region that makes it less stable in the pandemic strain. That, because we use the exact copy that got introduced into our vaccine, because that was the sequence we were supposed to use for the vaccine. Currently now, the strains have lost that particular change. So we are very, very interested in making a change in our vaccine going forward, and this would be for the 15-16 season then, if the strain doesn't change. But what we would do is get an antigenically similar strain to that 2009 H1N1 California strain, but which does not contain that mutation that's undesirable in the stalk. So that would be one of the more recent strains. It would be an update.
Okay. And as a follow-on question, do you have thoughts about ways to then assess either the thermostability or the infectivity that would help you decide that what you have is a better strain than the one currently in the vaccine?
Yes, for sure. Yeah.
Dr. Kemp?
I guess I'm a little confused about whether the lot issue is really the issue here. Was it possible to look at the different lots in these other data sets, for example, the Air Force data? I mean, that there was really variability between lots.
Yeah, I do not have the data for the Air Force by lot. I don't think they looked at it. These are the data that we have for the USVE network, analyzed the same way for lots. So we do not see it in the USVE network.
And Dr. Romero.
So this question, and let me apologize for not knowing what the distribution of LAIV is in the southern hemisphere, but could you get data regarding the effectiveness of LAIV from countries in the southern hemisphere that are using it and be able to get better comparative data?
That's a good question. I am not certain just how prevalent licensure of LAIV is in the Southern Hemisphere, and I would welcome a comment about that from MedImmune. It is licensed in Canada and the UK, United Kingdom, Germany, Israel, those countries that we mentioned earlier that have expressed a preference. But in many of those countries, it's only been licensed relatively recently. We've had it since 2003, but Canada and the UK, for example, it's been relatively recent.
What about Australia?
Kathy?
No, the vaccine is not licensed in any of the Southern Hemisphere countries currently.
Thank you.
Just a couple follow-up questions, I think, pertaining to the VE estimation, but the first is, and I think I know the answer, but in the usual approach, is there any assessment of illness severity with the people who are presented with ARI and cough, and is that possible? And the second question is, how rapidly can we get the annual VE answers after the season's over?
Validity and cough, and how quickly can we get answers to this after?
Why don't you answer that quickly first?
The second one?
Yeah.
Or the validity for cough?
Dr. Bologna.
So I'm sorry, Dr. Timothy, the first question was the validity of cough for ILI?
No, the question is there any ability to assess severity of illness?
Oh, okay. Yeah. In the USVE network, there have been a couple of attempts to look at scores that are essentially cumulative numbers of symptoms and self-described severity of illness. So these are all ambulatory patients. Those scores have not differentiated very well in terms of looking back at differences in vaccine effectiveness, and Ed Belange's group has done some of those. In terms of when we'll have data from this season, I think that in retrospect, we would have been able to look at the LAIV effectiveness for the 13-14 season earlier had we used interim data, which we don't typically use for vaccine-specific VE because we wait for the documentation and the verification. However, self-report is quite good for LAIV versus IIV types of comparisons. So I think that we will be able to provide interim estimates to help update this analysis. Again, it will depend on what circulates this season.
Thank you. Dr. Belange.
So, we have not seen differences in severity. However, our whole universe of people in the study are people who have already come in to see a physician, and we're not capturing people who have stayed home. Having said that, there's been some methods work on this that really suggests that the study design that we're using is actually under reasonable assumptions, probably a valid measure of vaccine effectiveness for preventing influenza illness, not just for preventing medically attended influenza. And then in terms of the other severity issue, in general, around 80 to 90% of the people that we enroll in the study probably meet the ILI criteria. Of the people with influenza, that is, meet the ILI criteria, even though we don't require that to be in the study. We only require cough.
Thank you. Dr. Shukat.
Yeah, I was just going to mention that for some years, CDC also supported vaccine effectiveness evaluation against hospitalized lab-confirmed influenza through the Emerging Infection Program Network. And after, I believe, a couple years of doing that, they concluded that there was comparable VE for hospitalization as for the medically attended illness, and it was more cost-effective to use the outpatient system for the estimates of VE and use the EIP network for estimates of disease burden. So I think for the more severe end, and I guess as Ed was saying, the less severe end, we think it's a reasonable approach.
Thank you. Dr. Decker has been standing patiently at the microphone.
I have two questions about the data presented. The first, there have been publications with respect to both LAIV and IIV suggesting that your response to vaccination depends in part upon your prior exposure to influenza vaccine. I'm wondering if the VE network has collected or might in the future collect information regarding the prior influenza vaccination exposure of the persons that whose performance in a given year is being evaluated.
Yeah, this is actually one of the questions that Dr. Reingold raised about potential confounders not being very convincing. And however, it's difficult for us to separate out this group that received LAIV from these sites that have relatively high vaccination rates. This is a table that just shows the LAIV recipients for the age groups in 13-14 compared with the receipt of vaccine in 12-13. And the group that is not here is the LAIV in 13-14 that was unvaccinated in 12-13 because we have so few of those. Almost all of these LAIV recipients had received either LAIV or IIV in the previous season, and several had received vaccines over several seasons. So the take home here is, if you look at the percentage positive here, flu positives, it looks very similar for the LAIV recipients. No matter what you received in the previous season, numbers are very small. And that's our issue with potential confounding. It looks lower in the IIV group for this season. Most of those had received IIV in the previous season. Just as in terms of how many cases are left out, there are 18 cases in the LAIV recipients in 13-14 here, and 11, so a total of 29. There were only 34 cases in the LAIV recipients total. So there are only a few LAIV recipients who either received 2 doses, so their first season in 13-14, or had received 1 dose but had not received a prior vaccination in the previous season. So we are looking at prior vaccination as an explanation. We do not understand the age-specific findings here, and it may be that they're not so age-specific. It's just something that's related to our sample size and the populations where these were done. Does that answer your question about prior vaccination?
No, those are interesting data, but that's not the question I was asking. So let me try again. The ACIP recommended LAIV preferentially for persons from 2 to 8. They didn't recommend it for the entire population because there's evidence that as you get older and have more experience with flu, the differential benefit of LAIV disappears, perhaps because you got enough antibody that you whack it in the nose before it does you any good. That's suppositional. So my question really is, has our improved vaccination of the pediatric population in the last decade, since those randomized studies were done, changed the environment such that LAIV is no longer as beneficial in the young people as it used to be because they've now had several doses of vaccine before the age at which LAIV is first indicated?
Yeah, and I understand the question. If you have a hammer, I think everything looks like a nail. I would still probably use the same slide to answer the question. we have a limited ability to look at the effects of several years of prior vaccination on take of vaccine, whether it's by type or whether it's any vaccination. That's an area of great interest and a lot of work in the VE network. It's difficult to do that with observational data. It would also be difficult, I would argue, to design a trial to look at that question. But it does seem that prior vaccination or prior infection changes your response not only to LAIV, but IIV. I would argue that the data that we saw in the 13-14 season in the flu VE network challenges that idea because both the young and the older kids had received several vaccinations. The older group might have been a group that had more natural infection to H1N1 pandemic during the pandemic, and it suggests that the older group, and maybe some in the younger group, received some benefit of vaccination, that it perhaps elicited their immune response, their memory response to that particular antigen. And what we saw in the younger group is that even in the younger group, even though they had been vaccinated, there appeared to be less response to the LAIV, and that's the group that if they had a low baseline, you would expect to respond better to LAIV. So I think the answer to your question is we still don't understand, but it's an area of active research.
All right, and then an entirely different question.
I'm going to, in the interest of time, move to Dr. Kimberlin.
I have a question about the 13th slide after your initial slide with your name on it. If you could go to that.
14th slide, so slide 14.
Slide 14 overall.
Can you go to slide 14 in that one? No. 14? Is this IIV effectiveness by age category?
Yes.
Okay.
Now, the slide before that, I think, or after that. I want to see, there's one that has H1N1, H3N2, and B.
Okay, I think that's going to be after, that's the comparison of the two vaccines.
Yes, they're over 3 seasons.
This is 2 to 8-year-olds, and then we had one, 2 to 18, and then we had one that was 2 to 8.
Is, for H3N2, with the 95% confidence intervals over 3 seasons, is LAIV not statistically significantly effective?
Yeah, that's right. There's just a slight overlap with no effectiveness there with zero.
We've been talking about H1N1 not being statistically significant, but we have to add H3N2 to that as well, correct? By these data.
I just argue that H3 specific estimates over 3 seasons are complicated by whether or not it's the same vaccine virus in the vaccine and what's circulating. With H1N1, we were very confident in doing that for these 3 seasons because there was very little antigenic change in what was circulating and very little antigenic change in the virus. So we have done multiple year analyses of H3 effectiveness, but as Lisa presented for trials and things, they often use all flu and sometimes will break down match by antigenic match and mismatch to the vaccine. And those things are mixed in here. So the 3-season analysis was not really meant to do the comparison of LAIV to IIV for the H3N2 subtype. But yes, I think that we could certainly say that there are issues with both vaccines in terms of the effectiveness of the H3N2s for the younger group.
Dr. Curran. Thank you.
Sorry, Brendan, could you also just show that slide for the 2 to 8-year-olds, which I think is the next one? Yeah. So your point still holds, but it's a little different, the distributions.
Dr. Kemp? Did I see your hand up? No. Okay. Dr. Plotkin.
Yeah, 2 quick points. One is that the stability problem was reported by MedImmune in January of this year, meaning that they knew it well before that time. So that suggests to me that the standard stability tests that are done for licensure should have shown a problem with the H1N1 strain. So I think MedImmune might have data anticipating what happened. But the second point is for the future, that we all believed in or believe in LAIV for young children based on the prior studies. Now, those studies were of a live vaccine that induced both serum antibody and mucosal antibody. I think for this coming season, that study of immune responses should be repeated, because there's no magic involved in this. If those same responses can be shown, it would indicate that the problem in the last year will not be repeated. So it's crucial. And the last point also is that MedImmune should have retrieved material that was sent out this season to titer it, because it is a live virus. And therefore, you can determine whether you still have a potent vaccine or not by titering the material that was put in the freezer or wherever in the far-flung places where it was used.
Dr. Scheffner.
Yeah, thank you. A comment and a question. My comment is, if this is a stem stability problem, I'm still confused about the age effect and the postulated lot effect. But that aside for the moment, I'm very curious about the FDA's role in this.
Yeah, we had a discussion with CDC on these data, and I guess it was a while ago before this meeting. And we have also undergone some internal investigations looking at the immunogenicities of vaccines through our evaluation process. But I think at this point, because there are so many potential variables as to that could explain this phenomenon, we're still in the investigational stage. And obviously, we will need to have further discussion with MedImmune if there are other things to be done. But I think right now we're taking these results and trying to interpret what they really mean and trying to figure out, as we all are, what the explanation is. And right now, I don't think we have that yet. And so this is a work in progress.
Gentleman at the microphone, MedImmune?
Yes, Chris Ambrose from MedImmune. Just to respond to the question that Dr. Plotkin raised. Dr. Plotkin's correct. So this mutation was known. It was in the the pandemic 2009 a California strain, which is why it's in our vaccine strain. The monitoring of the stability of the 2013 vaccine, like all years, is done. So we put several lots on stability, and we monitor the potency over time. That is stored at 2 to 8C, without any deviations from that, the recommended storage for the vaccine. So we did not see a stability problem with any of the monitored lots with the H1N1 vaccine strain. But what the data shows that's published in the paper is potential exposure to higher than 2 to 8C that could happen during distribution. But again, we don't have knowledge that it did, but we're investigating whether or not that could have happened during these warmest or hottest weeks of the year. For example, when it's being loaded or offloaded at distributors, taken off of trucks, things like that, it could be exposed to higher temperatures than 2 to 8C and potentially explain what we're seeing. And we are, to raise the other question, we are in the process of working with our distributors to look at the distributed vaccine for this year to assess the potency as well. Again, we've confirmed all the available data. There's no evidence of any breaks in the cold chain or anything this year or problems with potency. But again, we are going to try to look at distributed vaccine and confirm its potency from this year. So.
Thank you.
Sorry, Dr. Tempe. Just one comment related to the last two comments about if it was related to stock, why still have an age effect, and also why might it not show up on a stability assay? We actually don't know the answer to that, but I think one of the ideas that's been discussed is whether or not it might be a vulnerability subtle enough that it would not necessarily manifest itself on a standard stability assay, but perhaps again does have some effect on the replicative fitness of the virus in vivo. This is just, an idea that's been under discussion. That's something that might not necessarily show up and might not be inconsistent with an observed difference by age, because efficacy of any vaccine for influenza by age we know is variable for many reasons, and there might be some other factor that we don't know that's interacting.
Thank you. I think moving forward, it sounds like there is interest from the committee in assessments of lot potency out there by MedImmune. Definitely keeping watch of the surveillance for this coming year and seeing what strains are likely to be in circulation, which will definitely affect performance not only of the vaccine but of our recommendations. And then finally, I think there's a call for early availability of interim VE estimates out there from the VE network in terms of future planning. So I thank everybody here for a very interesting discussion here. I think we can move along to Dr. Altman and discussion of the Afluria influenza vaccine via PharmaJet.
Good morning. I'm Dr. Chip Altman, head of U.S. Medical Affairs at BioCSL, and I'm glad that my topic is not quite as controversial, and I'll be able to be pretty short in my presentation, but I want to tell you about something that's new. It was mentioned earlier this morning that Afluria got approved for use in a new delivery system, and it's not something for every patient, but it's something that's a really important option that I want to talk about today. It's a needle-free delivery system for Afluria flu vaccination. There's a term you might not know called trypanophobia, and it's a real term. It's a fear of needles. It doesn't just apply to children, because I know when I take my kids to the pediatrician, they get very scared of having a needle, of course, but it also applies to adults. In fact, recently published surveys show that about 1/4 of all adults fear needles. And what that means is about 7% of adults, it's estimated, avoid immunizations out of fear of needles. Some very prominent people actually fear needles. There's a talk show host. There's a former heavyweight boxing champion. There's a very famous karate stuntman. All of these people avoid needles. They can't get insurance. They don't get adequate medical care. So we take it really seriously, this needle fear. The fear of needles is a barrier to immunization, not just for the patients, but sometimes for the people administering the vaccines. Of course, we know needle stick injuries are something to be feared, and there are 800,000 estimated needle stick injuries in the U.S. each year, with a big fiscal and also psychological burden. But if you think about places where flu vaccination might occur, such as in a workplace, you might think that it would be good to avoid the use of needles in certain settings. I know in my workplace they wheel a cart around to give you the flu vaccine, and there really isn't a great way to dispose of sharps. So the advent of being able to deliver a flu vaccination without needles at all in the process is an important option. And that's why BioCSL partnered with a very innovative device company in Colorado called PharmaJet, and PharmaJet developed a Stratis needle-free injection system. Actually, jet injection systems for giving shots are not new. They've been around 100 years, and in World War II, a lot of immunizations were given by jet injection. Some well-received, some not so well-received. But PharmaJet has developed a new and improved system for delivering the flu vaccine with Afluria. This is what it looks like, and this giant injector has a little cartridge at the end of it. It's a single-use cartridge that's filled, and it injects a very thin fluid stream to the proper depth to get into the muscle, just like we would with a needle and syringe. And this all happens in about 1/10 of a second. So the jet injection fluid pierces the skin, goes right into the muscle at the appropriate depth, and the vaccine is administered, and that's how it works, very quickly. So anyone who says, I can't get immunized because of a fear of needles, now they have an option to get Afluria without any needle. And in fact, in the whole process for the healthcare provider, there is no needle involved. The multi-dose vial of Afluria that's used with needle and syringe can also be used with this PharmaJet system. You just pull back on that little plunger. It's a lure lock, no needle at all. And then the little cartridge gets attached to the spring-loaded jet injector. And then at a 90-degree angle, it's put against the skin right at the deltoid. And when you press the button, the pressure of the fluid goes right into the skin and to the muscle. And then finally, the little cartridge is discarded. In many states, it can be discarded in a non-sharps container because there's no needle. And then you can reset this and start all over again. I believe the amount of time it takes to use the jet injector is comparable to what it would take to use a standard needle and syringe. To have this FDA approved, as we mentioned, which we received recently, we had to do a randomized controlled study. We called it the JIFFY study, the Jet Injection for Influenza study, a randomized controlled clinical trial in healthy adults. It was done at the University of Colorado Health System. 1,250 adults ages 18 to 65 were recruited, and it used the standard Afluria trivalent influenza vaccine. And the whole idea of the study was to show that the jet injection with Afluria was non-inferior to needle and syringe in terms of immunogenicity. This was published in The Lancet in May of 2014, so you can look up this article if you want to get more details. Since the study was done in 2012 and 13, the prevalent strains were used, H1N1, H3N2, and the B strain. And, of course, the primary objective was to show non-inferiority of the PharmaJet Stratis jet injection versus needle and syringe. But secondarily, we looked at safety and we looked at patient complaints. Was the jet injection comfortable and tolerable? Here's a schematic of the study. It was really looking at patients over 28 days, taking their blood at day 0, then again at day 28, soliciting adverse events for the first 6 days on a diary card, and then the rest of the month was done by spontaneous adverse event reporting. It was randomized but not blinded, so patients knew if they got a jet injection or if they got needle and syringe, but the people evaluating safety and evaluating immunogenicity, they were blinded. So the study was partially blinded in that way. And the 6 co-primary endpoints were the GMT titers for each of those 3 strains and the seroconversion rates for each of the 3 strains. There were criteria set up in advance of the study for non-inferiority, but it didn't even come close. I'll show you the results. But just in case, the ratio had to be less than 1.5. In other words, when you look at the immunogenicity for needle and syringe divided by the immunogenicity for the jet injection, the ratio had to be less than 1.5 at 28 days, and the seroconversion rate differences had to be less than 10% to show non-inferiority. Secondary endpoints, as I mentioned, included safety endpoints, adverse event reports, and some solicited adverse events through the diary cards. Also, seroprotection and the geometric mean fold rise were also looked at. And finally, we wanted something sort of soft to ask patients, did you like the injection? Would you take it again by jet injection if you received it? Looking at the results, the populations in the 2 sides of the study, the PharmaJet jet injection versus needle and syringe were comparable by age, by sex, by race, so comparable groups. And here are the results. If you look at the geometric mean titers, they were really nearly identical for the jet injection in red versus needle and syringe in gray. B, as you know, the B strains are generally less immunogenic anyway. That wasn't a surprise. But if you look at the bars for each of the strains, they're nearly identical, showing that Afluria administered by jet injection really gives you the same immune response as Afluria administered by needle and syringe at day 28 post-injection. That's the GMT results. Here's the seroconversion rates, showing a 4-fold increase in titers. Again, the percentages are nearly identical for the jet injection versus needle and syringe. So the criteria really were met for non-inferiority, on both of those grounds, on the GMT ratio and on the seroconversion rates. Some of the secondary endpoints, like the geometric mean fold rise, again, very identical for the PharmaJet Stratis and the needle and syringe. And the same was true for seroprotection, achieving a titer of 40 or greater. So overall, you see very little difference between Afluria when administered by jet injection versus administered by needle and syringe. What about for safety? What do you think? Do you think they were equally comfortable? Actually, in terms of immediate complaints, there were more immediate complaints with the jet injection, but these complaints were short-lived and they were considered mild or moderate in severity. They went away in a few days, and they were mostly around the areas of pain, tenderness, itching, and redness, whereas swelling and bruising was comparable between jet injection and needle and syringe. But there were some more early complaints, in the first 30 minutes, in the first few days with the jet injection. Systemic adverse events were comparable between jet injection and needle and syringe. And serious adverse events, there was one serious adverse event in the jet injection group and 2 in needle and syringe, but none of these 3 were deemed related to study drug. And then when patients were asked, those who got the jet injection, would you choose to receive this again? About 90% said they would receive it again. We've gone on and done more post-marketing surveys. I think we just did one at the University of Tennessee. We asked people who received Afluria by jet injection, would you get this jet injection again next season? And we're getting rates of 75, 80, 90% of people saying they would prefer the jet injection again, despite some of those early complaints that are mild and go away. So this is a short presentation, but in conclusion, needle fears are a big issue. They are a barrier to immunization and to flu vaccination. And by having the option of giving Afluria by jet injection, we're lowering one of those barriers, which is important. We demonstrated in the study that was published in The Lancet that the immunogenicity was non-inferior for the PharmaJet needle-free jet injector versus needle and syringe. There were more local injection site reactions with the jet injection, but they were mild and moderate. They went away. And there was no difference in systemic adverse events. And furthermore, it was well accepted in post-marketing research. So the overall goal we have at BioCSL is to raise the vaccination rates for flu, and the option of using Afluria with the PharmaJet jet injector is another way to expand who gets the flu vaccine, especially in adults, which is the population of greatest need that's avoided vaccination in the past. So I can take any questions if you'd like.
Thank you much, Dr. Rungold.
Thanks very much for that. I'm old enough to have worked with what are called PharmaJets in West Africa, a needleless injection system where we could administer vaccine to large numbers of people without a needle. And one of the concerns with PharmaJets and MetaJets had to do with if the machine wasn't directly perpendicular to the skin, you could actually produce blood, either through some sort of shearing or cutting kind of phenomenon. And there were problems with blood contamination of the port around the injection, the insufflation or whatever the correct term is. So you haven't presented any data about what's known about blood contamination around the whatever you call the thing you're pressing up against the skin, but I'd be curious to know what we know about the safety with regard to transmission of blood-borne viruses.
My understanding is it's that little disposable cartridge that makes the difference. It's about 1 inch long, so that whole cartridge that you use to fill up from the multi-dose vial gets discarded. So there is a separation between the skin and then the actual jet injector. But we haven't seen a problem with that. But again, that piece is disposable. There's no needle involved with that cartridge piece. And in many states, as I say, it can be discarded in a non-Sharps container. Some states still would say it should be in a Sharps container.
Dr. Harrison?
Yeah, actually, Art asked my first question. The second question is, did you ask which vaccine would you prefer rather than the way you asked the question?
No, the way the question was asked, those who got the PharmaJet jet injection were asked, would you be willing or would you prefer to receive this one again? So they didn't.
I'm sorry, those are very different questions. It sounds like you asked it, you didn't ask preferentially, you just asked, would you get this vaccine?
Would you?
again?
Yeah, I think it was, would you get this vaccine again in the jet injection? It's true.
I think it's your next slide. It looks like it's would you choose, so.
I don't think it's in this deck has been changed a little bit.
Okay, Dr. Romero.
So very interesting work. Question I have is, what about the thickness of the adipose tissue in the arm? So in an obese individual, would this device be sufficient to deliver the vaccine to the muscle and not deposit it in the fat tissue? And just a comment, for those of us who don't like shots because it hurts, this doesn't help us much.
Right. What we know now is it is a one-size-fits-all for adults. And it was only studied in adults, and it was only studied with Afluria. But there's not been any stipulation about the size of your arm or obesity or anything like that.
Dr. Vasquez.
Dr. Romero asked my question, but I'm thinking, as we'll hear in the general REX session, that the depth matters. And I was thinking about obese patients, but do you have data to show that the penetration in the jet in different individuals remains the same? Is there actual, and I don't know how you would do that, whether it would be skin biopsies, et cetera.
Yeah, I don't have data on that, but again, in the development of this, that depth is supposed to reach the muscle and get in there in really all different sizes of adults. So.
Because it might be that for this particular vaccine, it doesn't matter whether it's actually how far in, but thinking ahead for other vaccines, it might make a difference.
Interesting. I think there are probably some folks from PharmaJet here you could talk to. I'll direct you to them. They may have more information on using that with something else. But for flu, only Afluria was tested.
At the microphone from PharmaJet.
Yes. My name is Heather Potters, and I'm the co-chairman of PharmaJet. So to answer some of the questions for you, if I recall properly, we have a syringe that has an auto-disable feature, cannot be reused, and the very end of the orifice touches the skin. So when we create that high velocity of fluid that penetrates the skin, for a moment there's an opening in the skin, and in theory, there is a split second where tissue fluid or blood could be seen because we're creating a hole. However, unlike the PETAJECT, we have no laceration issues with our technology, and we've modulated the spring to be appropriate to deliver to target tissues. So to address that issue, we have 510K data that has been submitted to CDRH that includes gel studies and tissue studies to demonstrate depth of penetration. We've also done our own studies with respect to imaging. We also have a variety of other vaccines that have been studied, most all of them intramuscularly, but subcutaneous and also intradermal. Including in our intradermal activities, we've had evaluation of depth, amount deposited, and I think that our engineering has adequately addressed the concept of can you get it to the target tissue. And with respect to the subcutaneous delivery, if you're going intramuscularly, you're compressing that subcutaneous tissue as you're delivering the injection. So we're very confident that it is, in fact, reaching the muscle.
Thank you very much. I have Ms. Pellegrini, Dr. Freihofer, Dr. Rubin, and Dr. Foster. So, Dr. Pellegrini.
I will just note briefly, thank you, Dr. Romero and Dr. Vasquez, for asking both of my questions about pain and obesity. Obviously, these are issues that a lot of people are going to want the answers to.
And Dr. Rubin.
Just a different question about the infection control aspect, since the common use part of the device is reused, so presumably this is reloaded. Vaccinators are allowed to either wear gloves during vaccination or not wear gloves. Obviously should be performing hand hygiene. Is there any recommendations of wiping this down, decontaminating it between patients or between reloading of the device?
Once again, I'm Heather Potters from PharmaJet, and I think that we have addressed that with the user interface in that the injector never touches the patient, and that single-use syringe, there's an auto-eject button on the injector so that once that injection has been given, you actually never have to touch the patient or the syringe, and it can be adequately disposed of. We've also tested all of the materials in relation to our injector. A number of common disinfectants can be used. There are heavy plastics and titanium-coated steel. So I think that you'd find that we meet all of those ISO standards required for hygiene and good practice.
Thank you. Have Dr. Foster?
As the University of Tennessee representative who actually was highly involved in that particular group, to answer one of the questions, we gave this was in healthcare providers, but we gave them a choice. We gave over 2,000 vaccines in one day, and 1/4 of them, about 500, actually went straight for the PharmaJet. They wanted the needle-free. I actually got it myself just to try it out, and it is not pain-free, I will tell you that. But I didn't see any differences with me and the needles, so it was accepted quite well.
Thank you for the testimonial. I have Dr. Schmader.
Ken Schmader, American Geriatric Society. So why did you exclude people over the age of 65 in your study?
This study was really designed, I think, with FDA guidance to look at adults. We did not study the elderly in this particular study, but I think it's something to do in the future for sure for us to think about.
And Ms. Evans?
This is Susan Even. I'm with College Health, and I'm interested in how fast it might be because it seemed like it might be faster than injections. Our nurses are preferring single dose for mass flu clinics, and I was just curious why it seemed like it was the same.
I believe it was comparable, but Heather can probably answer that.
Indeed, we have conducted a number of time studies and trials, and we are comparable to downloading with a needle and syringe if it's one individual. But in mass immunization activities that we've participated in, it's been deemed to be several times faster. There is a process associated with loading the injector and downloading, and that can be curtailed with a little bit of extra help.
Dr. Freihofer?
Okay, we've heard all about it. How much does it cost? I've tried to find this on the internet. I got an email from the company one day this week. I wrote a note back. Still no response. How much does your little gadget cost, and how much do your little cartridges cost in comparison to regular flu vaccine?
For Afluria, it's the same multi-dose vial that you would use with needle and syringe.
What about the cartridge?
Boy, it's a tough audience today. We are we compare very favorably to needle and syringe delivery, and it's really on a look-through basis where we have our syringe that is slightly more expensive than a needle and syringe, but there is generally a reduction in the sharps disposal. Many choose not to use sharps disposal. There's no treatment cost, no liability, no needle stick testing because there is no risk of that. So we tend to be also efficient in vaccine recovery. We have engineered the device so that there basically is no wastage of vaccine. So I think it's a very, very compelling delivery method that is highly cost effective. More than that, in terms of the injector, we have tested it to 30,000 cycles. We warrant it for 20,000 uses. We actually don't know when it will fail. And depending upon the volume of the user, we tend to sell that for $250 per injector. So it's fractional pennies per delivery. And of course, if people are buying large quantities, we simply give it away.
And the injector's used for 20,000 times? Is that what you said?
We warrant the injector for 20,000 uses without failure.
And how much is the cartridge, the retail price of the cartridge?
In our historical experience, it tends to be about $1 a shot. In our historical experience with respect to needles, they tend to be somewhere between $1.08 and $1.35, depending upon the needle solution that's used and whether or not 2 needles are used to download the vaccine from the vial.
There's been a lot of interest in the discussion. I'm going to have Dr. Gillen, Dr. Riley, and Dr. Harrison will have the last word.
Thanks. This is also a PharmaJet question. This appears to be an Afluria-specific relationship, and the question is where you are with other formulations, other manufacturers for increased flexibility in programs down the road.
Thanks for your question. Broadly, we are working in a variety of vaccines, clinical testing with our collaboration partners, and we are highly interested in being an effective tool for influenza vaccines. But our partner here with BioCell Afluria, we're looking forward to more and longer-term cooperation. These details are things that we don't generally share, but we are extremely supportive and grateful for all of the support that everybody has given to us. We have a great relationship with the CDC, WHO, FDA, and if anybody would like to come and speak to us, we'll be back in the corner after this presentation.
Dr. Riley, you actually get the last word.
I don't need to say anything. I wanted to ask the cost question. Thank you.
Okay, thank you very much. I think we will move along then to Dr. Santoli and the, Dr. Groskopf.
I was asked to, as part of the vaccine supply event that's about to occur, I was asked to give some influenza-specific vaccine supply comments prior to Dr. Santoli's presentation, just specific to flu vaccine. So I just have two slides. This slide shows the national distribution of influenza vaccine data provided to CDC by influenza vaccine manufacturers and distributors for the past 10 seasons. Seasons represented in different colors. The present season's data are shown in the bold black line. The distribution curves from more recent seasons are shown in darker colors, earlier seasons in the more faint colors towards the bottom of the graph. As you can see, the distribution for the current season did start off more slowly than many previous seasons, but exceeded last year's rate of distribution in mid-September and is currently at approximately the same level as vaccine distribution was in the 2012-2013 season. So that's more or less national, very high-level data. So on the national level, current projection for the U.S. market across all manufacturers was 151 to 156 million doses. This projection exceeds the total doses distributed during the 2013-14 season, which was 134.5 million doses. As of October 17th of this year, 117.8 million doses have been distributed. Overall, this represents approximately 75% of the vaccine anticipated for this season. Despite some early season shipping delays experienced by several U.S. manufacturers, including GSK, MedImmune, and Sanofi Pasteur, manufacturers anticipate that the majority of their flu vaccine distribution will occur by the end of October, with some providers continuing to receive partial shipments during November. Again, this is the national picture. Sometimes in some areas on a local level, things can be different. National level flu distribution data, vaccine distribution data can be insufficient to characterize the distribution at the local level. For example, because the early season shipping delays impacted certain vaccine brands and specific products within brands differently, some providers, depending on what was ordered and when, may be experiencing spot shortage while other providers are not. That's all I have on this topic. I'd request to refer any specific questions regarding to delays to the manufacturers.
Dr. Bocchini.
I was just going to ask, is the VFC distribution of flu vaccine on par with the private sector?
Dr. Santoli is nodding yes.
Other questions? Dr. Bennett.
Yeah, can I dig on that a little bit more? My understanding from providers in our region was that VFC distribution is limited by your prior month's order, and that there's been an issue this year with respect to big providers getting sufficient doses from VFC. Can you comment on that?
I'll defer the specific questions regarding VFC to Dr. Santoli, if that's okay.
So, Dr. Santoli.
So with VFC distribution, there's an important role that the state programs play in terms of how they want to allocate those doses to providers. So not every state operates in the same way. Some determine certain providers might be a priority provider because of the patients they're serving. And partial shipments are actually pretty common to get everybody started so that no one has no vaccine, even if there's not enough vaccine to fill entire orders. So I think I guess it's the national-local split again. At the national level, we received doses in a way that was comparable, but the way each jurisdiction may have handled their distribution was probably not identical. And so depending on what provider's orders, they may have experienced different things in one jurisdiction than another jurisdiction. But I think overall, we received doses equitably with the private sector. I don't know if that answers your question. So I have a very brief update on non-flu vaccine supply, and I was going to cover pertussis-containing vaccines and then a little bit about adult hepatitis A and B vaccines. So in terms of the pertussis-containing vaccines, after some vaccine supply constraints for the past couple of years, Sanofi Pasteur reports that they have sufficient supplies of their Pentacell, Daptocell, and Adacell vaccines. And for this one, it's an update from the last meeting that the Adacell includes both the vials and syringes. And they've been able to remove all of their allocations or ordering controls for these products. Another pertussis-containing vaccine is GSK's Kinrix vaccine, which is the DTaP-IPV vaccine. And currently there are some shipping delays for the Kinrix product. For adult hepatitis A and B vaccines, GSK's Twinrix vaccine, which is a combination Hep A-B vaccine, is currently out of stock in the private market. This is a vaccine licensed in those 18 and older, so its use in the VFC program and in children is very limited. However, adult formulations from GSK of hepatitis A and B vaccines are available in sufficient amounts to meet anticipated demand for adult hepatitis A and B vaccines. And then just a last brief reminder that we have a vaccine supply webpage on the CDC website that we keep up to date that's available to look at between meetings and will be updated after this meeting with what's been discussed. That's all.
Are there any questions for Dr. Santoli? If not, thank you very much for getting us back on time.